we're all on the same page. Oh. It's by no means all encompassing, but just a real quick overview. So as far as strokes go, there's two types of strokes that we think about. The main one being ischemic strokes. This is the most common, with 85% of all strokes being ischemic in nature. And that's when you have an occlusion of the blood flow to the brain. It can either be thrombotic or embolic. And then we have our hemorrhagic strokes, which is 10 to 15% of all strokes. And that's when you get some form of bleeding in the brain. It could be from trauma, it could be spontaneous. A lot of times these patients are on anticoagulants, where us as pharmacists have to work to figure out if they're on anticoagulants and how to reverse that. I work with the neurology team, and the neurology team will assess symptom severity using the NIH stroke scale, which looks at limb weakness, facial droop, speech, mental status, and all of those things to get a picture of how bad the stroke is and the disabilities involved. And then we will go to the CT scan, because it's important to get brain imaging to determine if the stroke is hemorrhagic or ischemic in nature, because that lets us know how we need to treat it. So for ischemic stroke treatment, the main goal is to restore the blood flow to the brain. Ideally, within 60 minutes of clinical contact or in our inpatient unit, the symptoms of the stroke, we want to restore that blood flow either with fibrinolytic therapy or a mechanical thrombectomy. At the Cleveland Clinic, we do both. It really depends on what the neurology team would like. But the mainstay of therapy is fibrinolytic therapy. We use alteplase, and I provide the dosing here. So it's a bolus of 0.09 mg per kg over 1 minute, and then an infusion of 0.81 milligrams per kilogram over 60 minutes. But I have heard, it's not officially official yet, the Cleveland Clinic will be moving to tenecteplase for our fibrinolytic therapy of choice for ischemic stroke sometime in 2022. And I guess this is kind of a movement in a lot of American hospitals that will be switching to this agent. I believe the Mayo Clinic just switched over as well. And then our neurology team, occasionally after they administer the alteplase, they'll get repeat imaging to see the total clot burden, and they'll go in and do a thrombectomy on top of the fibrinolytic therapy. Or if the patients were not candidates for fibrinolytic therapy, they'll just go ahead and do the mechanical thrombectomy instead. So here is our contraindications to fibrinolytic therapy. In this case, we'll be talking about alteplase because that's currently what I use in my practice. So the biggest things that I look at when I'm looking at patients and respond to a stroke are listed here. So you want your patient to have a last known well within the last 4.5 hours. They can't have any history of previous intracranial hemorrhage, or in the last 3 months, they can't have had severe head trauma or an ischemic stroke. This is a big one because we do a lot of surgeries in Cleveland Clinic, and surgery does put you at risk of developing a stroke. So you can't have a major surgery within 14 days to get alteplase, and you can't have a structural GI malignancy or a GI bleed within the past 21 days. As far as lab goes, we look at the platelet count, and we want the platelets to be greater than 100,000. The INR, especially for patients on warfarin, we want the INR to be less than 1.7. For our APTT, which is how we determine our heparin, if our heparin's therapeutic, we want that to be less than 40 seconds. And our PT, we want that to be less than 15 seconds. I also included 2 things here that are relative contraindications, but still something we look at. So the first one is blood sugar. Patients who are hypoglycemic or hyperglycemic can present with symptoms of stroke, but it's not necessarily a stroke. It could just be symptoms of their blood sugar being out of range. So we want to make sure we get a blood sugar before we do anything with those patients and correct that first to see if their symptoms resolve or if they truly are having a stroke. And then with blood pressure, before we can give alteplase, we have to lower a patient's blood pressure. So if it's greater than 185 over 110, we will give the patient some antihypertensives in order to get them below that so they can be candidates for alteplase therapy. Then the biggest one that they look towards the pharmacist about is if patients are on anticoagulants and what the timing is. So if patients are on low molecular weight heparin at our hospital, normally it's enoxaparin, but we do sometimes see dalteparin. They can't have had a full dose or a therapeutic dose within 24 hours. And then for our thrombin inhibitors or our direct oral anticoagulants, they cannot have had a dose within 48 hours. Being on a full dose and fractionated heparin drip, if the APTT is therapeutic, is a contraindication. And then our patients on warfarin, it's contraindicated if their INR is greater than 1.7. But if they have a subtherapeutic INR less than 1.7, we can still go ahead and give alteplase. Then our next subset of strokes that we see and help treat are hemorrhagic strokes. The goal here is to rapidly correct coagulopathies to prevent further bleeding. So that's on us to identify the anticoagulation used and the timing of the last dose to see if they're eligible for reversal and what reversal agent we would choose. If patients have signs of cerebral edema, such as pupils being asymmetrical or what we call blown pupils, where pupils are bigger than what they should be, or if they see cerebral edema on CT scan, they'll order either 3% saline or mannitol, and we'll help them get the orders verified and supply those meds to them. And also blood pressure management. We want pretty tight blood pressure control for these patients. I included this here. Hopefully you guys can see it, but this is our oral anticoagulated intracranial hemorrhage reversal guidelines that they developed at the Cleveland Clinic, which is really just a tool we use as a pharmacist if a patient presents with an intracranial hemorrhage to kind of walk doctors through, okay, this was the anticoagulant they were on, this was the last dose. And at the Cleveland Clinic, we have pretty much every factor product available, which is unique to us. A lot of institutions that you may hear from don't have all these options, but this algorithm helps us determine exactly what factor product would be best to reverse the bleeding from the specific anticoagulant. And we'll use this further in some cases later on. The only thing this does not include is obviously IV anticoagulant, so heparin, or our low molecular weight heparin. We use protamine for those. And then for blood pressure management, we do help our doctors with blood pressure management as well, either recommending an agent or just helping supply the medications, and it depends on what our goal of therapy is. So like I said, before fibrinolytic therapy, before alteplase, the blood pressure has to be less than 185/110. And then afterwards, we want to maintain a blood pressure less than 180/105. If the patient is not a candidate for alteplase, we allow what we call permissive hypertension. So we just want the blood pressure to be less than 220/120. And then for our intracranial hemorrhage, these are Cleveland Clinic specific recommendations. It's kind of very institution specific of what they target. But here, generally, we target a systolic blood pressure of less than 160 in our hemorrhagic stroke patients. All right, so that was our brief refresher. Now we'll kind of get into the pharmacist role and how our stroke response works at the Cleveland Clinic. So we actually have not always had a 24/7 pharmacist response. This started in 2020, shortly after I started at the Cleveland Clinic. Prior to the 24/7 pharmacist response, no pharmacist would respond to stroke. The neurology team would respond and determine what was needed. They would place an order and call the pharmacy. We would make the alteplase in the IV room and then delivered it to bedside. Like I said, the Cleveland Clinic is huge. So waiting for them to put in an order, compounding the med, and delivering it to bedside caused significant delays in treatment. It could be 20 to 30 minutes, depending on where the patient was before we delivered the alteplase. So it actually came as a call from the neurologist and also some of our joint commission standards for stroke treatment that we have a pharmacist respond to all strokes. So now a pharmacist will respond 24/7 regardless of where the stroke is in the hospital. And we actually bring the alteplase with us. We have a little red stroke bag that has alteplase and all the materials we need to reconstitute alteplase. So now we can go to the CT scanner and help with pre-mixing and getting the alteplase ready to expedite treatment, and we can get the alteplase in within minutes to the patient, which they are currently working on looking at our metrics because it's been officially a year since this started to see how our time to treatments have improved. So I'll be interested to see what those numbers show. So how our program works now, I included at the bottom is an example of what our pages will look like. So everyone on what we call our 2-clot team, which is just the acute stroke response team, has a pager, and any provider can page the 2-clot pager just with the patient info. So like if you see at the bottom, it will say G53, which is one of our hospital units, room 4. So we could then look up who the patient is in G53 room 4, work the patient up. We have Epic for our EMR, so our electronic medical system. So we can look at all the things that might make them contraindicated to TPA therapy, or if they were on anticoagulant and we need to worry about a brain bleed that needs to be reversed. So we do that, work up the patient, write down our notes, and then we report to the patient bedside. Every day, all day, 24/7, who responds is a junior and senior neurology medical resident, and then a clinical pharmacist will respond to the bedside. The neurology residents will then perform their bedside exam, do the NIH stroke scale to determine if they for sure think this patient is having a stroke and how severe they think the stroke is. And then after their exam, we'll proceed to the CT scanner. Based on the symptoms, they may ask pharmacy to premix the alteplase and get it ready after the CT imaging to confirm that it's not a brain bleed. It is in fact an ischemic stroke. We would then help them administer the alteplase. If we're worried about a hemorrhagic stroke or brain bleed, we would wait in the CT scanner to see if the CT imaging does in fact show a bleed, and then we would help them determine reversal agents. This is an example of one of our procedures. This one specifically is for the emergency department. So the patient will come in, we'll get their weight, the neurology will look at the patient, we'll bring them to the CT scanner. They can decide to premix the alteplase, which is just, we're pretty sure this patient's a candidate. We just have to wait for the CT imaging, but start getting it ready so we can give it as soon as we can. Then we'll decide to administer, and then pharmacy will get the dose ready and educate the nurse. And then from there, neurology would decide if they want any further interventions for the patient. It's very similar emergency department to inpatient. The only thing is when patients come into the emergency department, we don't have a full medical chart, so we don't know what meds they've been taking. We don't have their labs readily available or their blood pressure, so we kind of have to move on our feet and get things as they come in when we treat those patients versus inpatient strokes. So what do I do on the team? I am looked at for pretty much any kind of dosing or any drug recommendation. So before I even go up to the bedside, I look at all those things that we talked about for contraindications to alteplase. So I look at the patient's most recent labs, I look at their medication list and their administration record to see if they've gotten any anticoagulations within the past 2 days. If they are on anticoagulations, I already work out in my head what I'm gonna recommend for reversal if we need that. And then I look at their past medical history and if they're in there for any recent surgeries to also determine if I would recommend alteplase. Then when we come to the bedside, we actually bring the alteplase with us, so we are ready to premix it if they want that. We help with blood pressure management, especially for the patients who would otherwise be alteplase candidates, but their blood pressure is a little high. We help supply those medications, figure out what exactly they need, and get the blood pressure within goal. And then we help with the preparation and dosing of alteplase and provide nursing education. So these also, all of these guidelines I'm showing you, our neurology team has actually made us little pocket cards that we carry around with us. So if we forget, or if we're in a bind and we just can't remember how to do something, we have them with us at all times. but this is how they provided us all the steps to administering Alteplase. So if none of you guys have seen Alteplase before, it comes in 2 vials. The one vial is a sterile water, and then the second vial is a powder. So you will swab the containers, and we have a nice spike here that we spike the sterile water, and then can put the Alteplase on the other end of the spike, and then we invert it so the sterile water will go into the Alteplase vial. You can't shake it. We have a tube system, but it can't be tubed, which is why we had issues with delivering it before we started the pharmacist response. And then once it's reconstituted completely, we work at our dosing and help the nurse with priming IV tubing. We spike the vial. All of our vials are 100 milligram vials. So we have to look at the patient's weight, and we calculate the bolus dose and the infusion dose, and we label them so the nurse knows exactly how much they will be giving. And then we have to waste the rest. So we figure out how much we have to waste by taking 100 milligrams, so the total vial size, subtracting our bolus and infusion dose, and we will draw out the waste and discard it so the nurse doesn't accidentally give too much. Once we remove the waste, we then remove the bolus dose for the nurse, hand them the separate syringe, and we explain to them how the bolus has to be administered over 1 minute. And then we help them set up the IV pump to give the infusion dose over 1 hour. Some of our nurses have been to a lot of strokes and have given it before. Others have not, so we just make sure that they are comfortable with how to review vital signs, looking for any possible risk of bleeding, so that if they have further altered mental status or stroke symptoms, ideally their stroke symptoms should improve. But if they get worse, it might indicate that they have a hemorrhagic conversion. And then our nurses, just to make sure that they got the total dose of Alteplase, we help them after the infusion get just a normal saline bag and run that at the same rate as the Alteplase on the pump to flush out the tubing to make sure all the Alteplase went to the patient. So that was ischemic stroke. Hemorrhagic stroke, we also help with probably a lot more than ischemic strokes, because we have so many options for reversal strategies at the Cleveland Clinic that the providers don't have memorized what agent is best for what drug. So they rely on us pretty heavily for hemorrhagic strokes. So we'll look at the patient's chart, determine what anticoagulation was used and when the last dose was. We look at the chart to determine what the appropriate reversal agent and what the dosing would be. We don't carry these with us, unfortunately. They trust us with Alteplase, which is thousands of dollars, and these reversal agents are even more expensive. So I always joke that they don't trust me with that much money, so I can only carry the Alteplase with me. So we'll place the orders for these reversal agents and coordinate with whoever is working in our IV room, the pharmacist for that night, to make sure that they have the supplies needed for preparation. We round up to vial sizes. So whatever vial size we have in the IV room, we'll round that. And then we will walk back down to the pharmacy and get the medication as soon as it is compounded, and then bring it back to bedside. So kind of just being the procurement agent at that step. And then we'll make sure the nurse knows how to properly run it on the IV pumps. And these patients, oftentimes, if they have a hemorrhagic stroke, they'll be pretty hypertensive, and we want tight blood pressure control. So we'll also help make sure that they have the antihypertensive agents available to them and get those started. And then, like I said, if the patient has signs of cerebral edema, we'll help coordinate orders for hyperosmolar therapy and make sure they have access to those agents as well. All right, with all of that, we'll work on some patient cases. I kind of broke them up so you guys could work on them yourselves, so you can follow along with me. And then there'll be plenty of time for questions if you're wondering why I picked a specific agent or anything like that. So our first case, we are the emergency department pharmacist, and we had a 56-year-old male present to our emergency room with left-sided arm weakness, a facial droop, and some slurred speech. His wife I meant to put 1 hour ago. I don't know why I put 1 week ago. So just pretend like this says 1 hour ago. His wife reports that these symptoms started about 1 hour ago. And the paramedics who brought him in the ambulance say that his blood pressure is 140/96 and his blood glucose is 115. So from here, being in the emergency department, we can get their name and birthday and bring them up in our electronic medical system to see past prescription histories and some past medical history. But obviously we don't have what's happened to them in the past couple weeks, so we rely a lot on family as well. So we'll talk to the wife, see what medications he's on, see if he's ever had a stroke before, and then also kind of verify all that with the medical records. So that's our job as a pharmacist, to see any red flags of why this man would not be a candidate for alteplase therapy. So we do that. We talk to the wife, we look at his medical record. His only past medical history is a history of hypertension and diabetes. And he's on lisinopril 40 milligrams daily for his blood pressure, metformin 500 twice a day for his diabetes, and he takes an aspirin 81 milligrams daily. The nurse weighs him on arrival and he weighs 64 kilograms. While we are confirming all this with the medical records and the wife, the neurologist will start doing the NIH stroke scale, which results as a 7, which is considered a moderate stroke. And the nurse will start an IV and take some stat labs so we can start getting those processed in our lab. We actually have in our emergency department a stat lab room where we can get some blood work back within like 15 minutes. And then the rest we'll have to send off to the bigger lab for final lab results. All of this kind of happens rapidly at once the patient arrives at the door, and then we'll head to the scanner for what we call a CT brain attack, which is just a CT imaging for anyone that we suspect is having a stroke. So just looking at this man, me personally, I look at his meds. None of his meds, he's not on any anticoagulant. Being on a baby aspirin or aspirin 81 milligrams, not a contraindication. We said that his last known well was an hour ago. He doesn't have any history of a brain bleed or recent surgery or a recent stroke within 3 months. So, I mean, we don't have labs, but right off the bat, I'm thinking this man could be a candidate for alteplase therapy. I don't see any reason not to, so I keep that in the back of my mind when I go to the CT scanner. Our stat labs return while we're in the CT scanner, and our imaging shows no intracranial hemorrhage, so we're not worried about brain bleed. So we're going to be asked as a pharmacist to prepare the alteplase. The patient has no contraindications, so we're going to prepare it for administration. So when we're asked to do this, we then have to start calculating our dosing and how we have to get all of our syringes ready for the patient. So on the next slide here, I walked you guys through that. So the patient is 64 kilograms. So for our bolus, we would take 0.09 milligrams per kilogram multiplied by his weight. So our bolus that we will have the nurse give over 1 minute is 5.76 milligrams. We're going to draw that up into a syringe, label it, and have it ready. And then for our infusion, you take the 0.81 milligram per kilogram times his weight, and that's a 51.84 milligram infusion. So we'll get that primed and ready in the IV tubing and have the nurse run it over an hour. But before we can hand this over to the nurse, we have to take out our waste from the vial. So we have a 100 milligram vial that we reconstituted. You subtract your bolus and your infusion dose. So we have a 42.4 milligram waste that we have to remove from the vial. So at the end of this, we'll have our vial that the nurse will infuse from, which should contain 51.84 milligrams of alteplase. We'll have a syringe labeled to be given as a 5.76 bolus. And then we'll have a separate syringe with 42.4 milligrams that we will then waste to make sure the patient does not receive that amount of drug. So that brings us to a similar case, but slightly different. So this would be if I was the inpatient pharmacist. So in this case, we will be called to a 2-clot for a patient in the coronary intensive care. Pretty typical, majority of the strokes that I respond to overnight happen in our cardiovascular center. Most of these patients have significant risk factors for stroke or recently had cardiac surgery, and cardiac surgery does put patients at high risk of developing a stroke after surgery. So I spend a lot of time in the heart center. But this patient specifically, they are a 63-year-old patient who had a CABG performed 2 days ago with new onset right-sided weakness and altered mental status. So right off the bat, they had a CABG 2 days ago. This is considered a pretty major cardiac surgery. So I know right off the bat, this patient is not going to be an alteplase candidate. However, we still have to do our due diligence, look at the chart, see if there's going to be any further needs from pharmacy, and we still will respond to the bedside to help out. So I bring up her chart and I look at her meds and I notice that she's on a heparin drip, which majority of our CABG patients will be on a heparin drip after their surgery for some amount of time. Her heparin drip is running at 1,000 units per hour, and her last APTT was 43 seconds. So that is considered elevated. So that's another reason she would not be an alteplase candidate. I look at the rest of her labs. Her hemoglobin was 12 and her platelets were 99,000. So looking just at her platelets, even if she wasn't on the heparin drip, her platelets are also too low for her to be allowed to get alteplase therapy. So right off the bat, this woman has 3 contraindications to alteplase therapy. So I'll keep that in mind before I go to the bedside. You also want to look at her vitals and get her weight written down, just in case you do need to reverse something, or if this patient would be a candidate for alteplase therapy, which this patient is not, but you'd still need to write down the weight so you have that to do drug dosing. We go to the bedside and neurology will conduct their NIH stroke scale. This patient is having a moderate stroke with an NIH of 6, and we'll head to the CT scanner. My biggest concern with this patient, because I know that they're not going to be a candidate for any alteplase therapy, would be that she potentially has a hemorrhagic stroke from being on a heparin drip. But luckily this patient, the CT imaging shows no sign of intracranial hemorrhage. So she's likely having an ischemic stroke. So in this case, she's not a candidate for fibrinolytic therapy. Neurology would work with their fellows or their staff physician to see if she would be a candidate for a mechanical thrombectomy instead. All right, we're gonna flip gears and do some examples of a hemorrhagic stroke. So we're gonna put on our emergency department hat for this one. We have an 80-year-old male who comes to the emergency department with new onset altered mental status and a right-sided facial droop. His wife reports that these symptoms started a half an hour prior to the ambulance arrival. So they started and she called the ambulance right away. The paramedics in the ambulance took a blood pressure. It was a little bit elevated at 180/110, and they took a blood glucose and it was 116. We take a weight as soon as the patient comes in, just so we know for drug dosing, and the patient weighs 66 kilograms. So we will look at the patient's medical chart if we're able to pull up any information, and also talk with the wife to get some more history and see if there's anything that we need to be aware of as far as anticoagulants or significant past medical history. So in this case, we bring up the patient's medical chart and see that he has a recent prescription that he filled for apixaban 5 milligram tablets. Apixaban is a direct oral anticoagulant. So we're going to ask the wife when he last took a dose, because we'll be worried if the patient took a dose within the last 48 hours, that would be a contraindication to alteplase, and also be a big red flag that we might have to reverse the apixaban if it is a hemorrhagic stroke. So in this case, the wife reports that he took his dose tonight with dinner. So he very recently got a dose of the apixaban. The neurology will do the NIH stroke scale. In this case, it comes back as 12, and we rush the patient to CT scanner for imaging. The patient, in this case, does have an intracranial bleed, and they look to the pharmacist and say, how do we best reverse this patient? We see the bleed, we need to reverse it to prevent any further bleeding. So I said I'd bring this chart back. So this is when we look at our handy chart. So the first question in the chart is, which oral anticoagulant has the patient been receiving? We know that they were on apixaban. Then the next question is, have they received a dose within the last 48 hours, which the patient has. He took it with dinner. We also look at renal function. So in patients who have altered renal function, either an acute kidney injury or chronic kidney disease, or maybe on dialysis, they can actually hold on to these drugs for longer. So we might consider, maybe they took their dose 72 hours ago. It's not 48 hours, but they're on dialysis. So they probably still have the medication in their system. So we'd probably still reverse a patient in that case. So that why it's at ask last dose within 48 hours and normal renal function. So our answer is yes. And then we'll ask which oral anticoagulant they were on. Our patient was on apixaban. So our drug of choice for reversal is going to be FIBA. FIBA consists of factors 2, 9, 10, and then activated 7. Some of you have probably heard of Indexinate Alpha, which has been FDA approved for the reversal of direct oral anticoagulants. We do not carry it at the Cleveland Clinic. That was a decision of our hematology team and our neurology team, and they just looked at cost benefit analysis and current studies, and they decided that we weren't going to carry it on formulary. So instead we use FIBA to reverse our direct oral anticoagulants. So we tell the neurology team that we want to use our FIBA, and the dose is 50 units per kilogram. The patient weighs 66 kilograms, which gives us a calculated dose of 3,300 units. We'll be getting ready to put the order in, but we need to talk to our IV room pharmacist to see what supply we have. They tell us that they have 1,000 unit vials, so we'll round this dose to 3,000 unit total. So we can have a nice round dose for the IV room to make. The IV room will start making the medication. We'll also recommend the patient be started on a nicardipine drip, which at least in our care and our practice, we recommend nicardipine drips for first line in patients with intracranial hemorrhages for blood pressure control. We'll get the nicardipine drip started, and then we'll run down to the pharmacy to go get the FIBA real quick, and then help the nurse get that drip started as well. All right, so I have one more case. This case, we're going to be in an inpatient unit. So we will be paged with a 2 clot for a patient in the Heart and Vascular Institute. This patient is 60-year-old male admitted for acute coronary syndrome, new onset altered mental status, and right-sided weakness. So we're going to bring the patient up and start working them up prior to going to the bedside. In this case, we look at the patient's chart, and he is currently on a heparin drip running at 1,400 units per hour. His most recent APTT is 60 seconds. So for our institution, at least, this would be considered therapeutic on heparin. So right away, going to be worried about reversing the heparin, and I'm going to want to work out in my head what I'm going to use. Looking at his labs, his hemoglobin is 10, his platelet count is 150, and his glucose was 220. His blood pressure is slightly high at 160/98, heart rate of 90, and he weighs 70 kilograms. Keeping this all in mind, being therapeutic on a heparin drip is going to be our biggest contraindication of all the place, but we're going to worry about the bleed. We go to the bedside. Neurology will conduct the NIH stroke scale. This case, the patient was a 10, and we head to the CT scanner. This patient, unfortunately, did reveal that he had an intracranial bleed. So the pharmacist is then asked to order reversal agent for the heparin. At our institution, we use protamine for heparin drips and also low molecular weight heparins. And here's our dosing. So for our protamine dosing, we determined by taking the amount of heparin that was administered in the last 2.5 hours. That would include boluses and also the infusion. And we use a ratio of 1 milligram of protamine to 100 units of heparin, and a maximum dose that we will give is 50 milligrams of protamine. So even if the total was greater than 50, we would round that down to 50. And then further dosing would be determined based on hematology. We would consult hematology in that case and look at APTT results and determine if they needed more protamine. So for our patient in the case, he had 1,400 units per hour running. We multiply that by 2.5 hours. So he's received 3,500 units total of heparin in the past 2.5 hours. Then we divide that by 100 because 1 milligram of protamine will neutralize 100 units of heparin. And that will give us a total of 35 milligrams of protamine that we will need to reverse his heparin. Also, this patient was slightly hypertensive. It depends on what the neurology's goal is. Generally, we want to keep their systolic blood pressure less than 160. Some neurologists will want tighter control at less than 140. So if they are worried about that, we'd probably still get the nicardipine drip ready to be started, since they are kind of on that borderline of a systolic pressure of 160. Protamine also is nice because it just comes in a vial. We don't have to compound it from pharmacy. So normally it's in one of our automated med dispensing cabinets. So we don't have to run all the way to the pharmacy to get this for the nurse. We normally just have to run to one of the nearby units and can get it pretty fast. With that, there's my references. And do you guys have any questions? I'll stop sharing my screen so you can see me.
Cassandra, excellent presentation. Okay,
Thank you.
Really great way. And now all of you know why she was one of our top students. And I was very happy to present her as what we can do at University of Findlay for students, those who are really motivated. So thank you very much, folks. Now I'm an academician. I know I probably teach her cardiology. Now she can teach me back in a better way. So you guys tell us what is that? Remember, India is quite different, and I'm sure we are doing a lot of good surgeries these days in India. And many of the stuff was very comparable. So you can ask her any questions if you are doing something which is different than what they are doing, and that's the whole purpose here. So I'll open the questions to you. Unmute yourself, introduce yourself, and ask the question for Cassandra.
To all participants, if you have any questions, you can ask Dr. Cassandra.
Folks, it was a very nice presentation. I'm sure some of you are doing in a setting which is something different. So please do ask the question. If there is no question, then the speaker never know whether anybody understood anything which she has said. Okay, I mean, so please do. That's the whole purpose of this. It's not just one-sided talking, which all of us as students have learned. Many of our professors give you a talk, and at that time we are making the foundation, so you may not have any question. But now, when you already got a degree and you are using it in real life situation, you should have questions for this.
Hey, I do have a question, Cassandra.
Please. Yeah, Kenneth.
Yeah. Hey. My question was, where I work, we use Andexa for the reversal of those DOACs. And I was curious, do you happen to know, was there just like a specific study as to why they're using FIBA versus the Andexa, or was it just, you said hematology? I was just curious on where they were coming from with that, because we've been using Andexa.
Yeah, so some hospitals in America are using andexanet alpha. My understanding, it's very few and far between still, and most of them are research centers getting more data. I'm not actively involved in our P&T committee, but I think it was just looking at the amount of studies that are currently available on andexanet alpha. It's still relatively new, and the data that was there compared to the cost of adding it to formulary and how often we would use it and our success with using FIBA, I think they just said not right now. They didn't see a cost benefit. I mean, that's mostly what we use in our P&T committee is cost benefit analysis. I could foresee it. I mean, we have pretty much every other factor product available. I foresee potentially we might add it to formulary if more data comes available, or we are the Cleveland Clinic, so I could possibly foresee us even becoming a research center. But from my understanding, it's all just cost benefit analysis. They didn't add it to formulary.
I'll just like to add here that Ken Mueller, who just asked the question, was a 2012 graduate, if I'm not pronouncing this. So he was from University of Findlay also.
Oh,
and
okay.
He's working in Emory. He's working in Emory, and he contacted me in LinkedIn, and I said, you can also please give you, sometime you will talk down the road And because I already had Cassandra on the list, and I said, please come and join and see what type of presentations I would like from you. So this clearly shows that even within America, the two hospitals, there are some differences. So I'm sure between America and India, there must be a lot of differences. So please, I mean, you make my day and Cassandra's day by asking some good, relevant question. Thank you.
Yeah, I'll also
Thanks, Ken, for attending. Yeah, go ahead, Ken.
I'll also add kind of on that talk, I have worked at other hospitals that we didn't even have FIBA available. Some hospitals prefer not to keep all the different factor products. So I have worked at hospitals where we only had Cassandra or PCC available. So they would use Cassandra for reversal of both warfarin and our direct oral anticoagulants. So it's really hospital across America. Everything's hospital specific as far as what they're going to carry, how much money they have to supply medications, what the utilization is going to be. So I've even myself worked at hospitals that are completely different with what they use.
Ma'am?
Yes.
Yeah. Go ahead, Abhijit.
Yes, ma'am. I am doing Doctor of Pharmacy from Bharati Vidyapit. I have one question, ma'am.
Sure.
Ma'am, as we know, aspirin and metoprolol has drug interactions because aspirin reduces its effect. So if any patient go with cardiac surgery and doctor prescribe these two medications after dinner, so how much time intervention these two drugs should the patient take?
So I still see metoprolol and aspirin used quite a bit. They kind of go towards response. They'll look at the metoprolol and they will titrate it before the patient leaves the hospital to make sure we're getting adequate heart rate control, and then do close follow-up with the patient. And then all of our patient post-cardiac surgery will be started on 81 milligrams of aspirin. So that's just what I see in clinical practice that our cardiologists do.
Okay, thank you, ma'am.
Yeah, no problem.
Any more questions? Please, you can ask.
Yeah, hello, Ashish. Dr. Ashish, can I also ask a question?
Yeah, please.
please,
go
Abhishek.
ahead.
Hello everyone. I'm Dr. Abhishek Sharma. I have worked as a former clinical pharmacologist in Asian Heart Institute Research Center in Navi Mumbai, and I am right now associated as a quality officer in Jamia Hamdard. I used to miss my clinical pharmacy days. So with that, I have some queries that I've always used to highlight few things regarding the relative contraindication and absolute contraindication with medicines. So right now, taking the example of aspirin and metoprolol, which previously he was asking, my question is this relative contraindication, how much to worry about this relative contraindication? Is it really necessary, or in real practice, in case of critical care, we have to somehow omit it?
So you're asking me like how I feel as far as like the relative contraindication of aspirin and metoprolol, or?
Yeah, anything. It's a general question that how much the relative contraindication is helpful, or is there a scope of we can't ignore it, or something we can ignore it most of the time, because relative contraindications are much overlooked whenever I used to do any intervention. So the clinicians, they used to say when there is only an absolute contraindication exists with the therapy, then only we can take a call on that. Otherwise they usually don't take the call. So
Yeah.
can you just tell me out that how meaningful, how important is relative contraindication is?
So I think it's very drug dependent. What I would say, like with the metoprolol and aspirin, just in my practice and what I know our cardiologists do, we're going to use metoprolol with aspirin all the time, especially post heart attack patients. They're going to be put on metoprolol succinate and aspirin. So I guess just me having experienced that, that's something that I wouldn't page the doctors because I know that they wouldn't accept that as an intervention. But we do have other drugs that is not absolute contraindication. Like they can be on both, but we might have to worry about dosing or monitoring. Trying to think of an example. So an example I see a lot, it is a relative contraindication, but patients who are on valproic acid and meropenem can reduce the effect of valproic acid. So it's a relative contraindication, not an absolute contraindication. So in these kind of cases, you have to look at the data available. So what exactly is the interaction showing you, and why is the patient on both medications? So in this case, you know, at least in my practice, we use valproic acid for different reasons. We have patients who are on it for seizure control. They may have status epilepticus. And we also have patients who are on it for mood disorders, so agitation or bipolar disorder. So kind of my risk tolerance as a pharmacist, if I had a patient who was on it for a mood disorder or just some agitation, if they're on meropenem, they need to be on meropenem. Maybe they have an ESBL E. coli organism. It probably, I'm going to say like the risk of starting the meropenem, like they absolutely need the meropenem to treat their infection. However, if they're on valproic acid because they have seizures and have been in status epilepticus, I don't want to risk that valproic acid not being effective. So in those cases, I'd bring it up to the doctor and just be like, here's what the interaction is. Here's the possibility. You know, what do you want to do? Do you want to monitor valproic acid levels? Can we switch the valproic acid to something else? Or can we use a different antibiotic? So it kind of all, you know, absolute contraindications are always going to be like, no, you need to stop it. We need to do something else. But with relative contraindications, it kind of comes down to your clinical expertise of evaluating data. Sometimes you have to bring up studies and like look at what has been done historically and look at the context of the patient of how much those relative contraindications will matter. So it's very drug and patient specific for me.
Oh, thank you. Thank you so much.
Yeah, no problem.
Yeah, we are fine to take some couple of questions more. If anyone has any questions, please go ahead. Dr. Cassandra, it was a nice talk indeed, you know. So I believe the questions are less because the pattern that you have explained, it is quite new to India. So, you know, I believe slowly, you know, with with the progression and with the, mutual learning from both the ends, the questions will gradually increase in our next series of master classes.
Yeah, that's, I mean, like I said, at the Cleveland Clinic, we didn't even have 24/7 pharmacist response to strokes until last year. And that's at the Cleveland Clinic. So that's completely understandable. And it's kind of been a learning curve of how we developed our pharmacist response and had pharmacists respond to bedside. We are very fortunate that our all of our providers really rely on pharmacy. I mean, they would call us and like ask for help anyways, but now they have us at bedside and can like actively like look to us, be like, okay, you're here, I need help right now. So it's still even new in the Cleveland Clinic. So yes, we all start somewhere.
Yeah, it is a different practice in Cleveland Clinic, and I was lucky to do my observership in Cleveland Clinic. So I did my observership in Cleveland Clinic in 2019 in Abu Dhabi. So yeah, I have seen the actual ground practice happening there. So it is quite different from India. So I believe with the progression of this master classes, we'll have an understanding of how it being practiced in the Western countries. So if there is not much questions, we'll just conclude the session, sir. So please unmute yourself. Dr. Chandra, please unmute yourself, sir.
Okay, I'm talking. Okay, so I apologize. So I think I muted it, so no other background right come. So thanks very much, Cassandra, for giving. And I think I will again call upon you, maybe once or twice a year. Already done once, maybe one more year in the next 6 months, if you have another topic. And the purpose of my collaboration, of my efforts is basically we are not doing exactly the same thing, and the faculty and the practitioners in India can learn what's happening. This is the best way. It's almost most cost-effective way to educate them in this way. And then we can see what steps we can take to improve. That's all. So my actually wife worked with the Cincinnati stroke team. She's still a statistician for them. And one of the major emphasis is how fast you can get the patient the alteplase dose if he or she is eligible for alteplase. So if based on this conversation, if the hospitals start measuring what their current rate is when they are dosing, that should be even the first step. So, okay, so that's the whole idea. And I thank you, Cassandra, for coming. You did a star performance. Okay, so you got name star in there anyway. Did a great job. And Ken, thank you again for attending this presentation. And I will hope to get back to you, and you will be presenting in the not too distant future. Thank you.
All right. Yeah, no problem.
Goodbye.
Thank you so much,
Goodbye.
Dr. Cassandra, for giving
Yeah.
your wonderful time.
Cassandra, just text me your home address, please. Okay. When you
Okay.
go, just send me a WhatsApp message. And
Okay, thank you.
folks, yeah, thanks, Ashish, for hosting this thing. And if anybody has any question about the program we have about the Ashish Fellowship, they can ask them. And otherwise, we will just end the program at this point. From the Indian perspective, no technical stuff, so anything else.
If Vijay sir wants to add up anything, sir.
Yeah. Yes, Ashish. Anything else? Okay. Thank you very much for all those who attended. Hope you learned something, and we'll see you. Next presentation is on November 13th, and the same time, and we will meet again. Take care.
Yes, thank you all the participants for joining us. I hope you have liked the webinar, and you will be with us in our next webinar, Masterclass Series 2. And I'll be releasing the poster very soon. So please join us. And also after this webinar, I'll send you a feedback form. So please fill up the form and send it us back so that we could do any if anything we have lacked today, we could do better in our next masterclass series. So thank you, and be with us. Have a good day, sir. Have a good day, Dr. Cassandra.
Bye-bye.
Bye-bye.